There were several years back where we were getting ready to set up. We had a big meeting going, and Jim came up to me and said, "You know, Craig, I've watched your work. I'm really excited about what you guys are doing, but I don't see that you're using much CO2. I said, "That's right." And he says, "Why is that?" I said, "Well, in my training, I thought CO2 was a very difficult way to get a bad image." And he said, "If I can show you differently, would you consider using it?" And I said, "I sure would." So Jim actually took time off, took his vacation time off to come and work with me, and that's the kind of devotion he has to CO2 imaging. And this was really eye-opening to me because contrast-induced nephropathy and severe allergic response to iodinated contrast media are huge. And then I got to a point where I had a man who came to me. He was a very young man. And he says, "Craig, I have these lesions on both legs." And sure enough, he had a gangrenous toe on one leg, and he had a non-healing ulcer that had not healed for 2 years on the other. He was diabetic. He'd been a smoker, but he had quit. And he says, "Do you think you can help me?" So we checked him, and sure enough, he had a horrific disease. But I said, "Maybe I think we can." He says, "Well, there's one other problem." I said, "What's that?" He says, "My creatinine is 5. I said, "Oh." He says, "I only have one kidney." I said, "Oh." So then he says, "You know, I haven't been doing so well." I said, "Well, we might be able to get around that because we have CO2. And he says, "But there's one other problem." I said, "What's that?" He says, "Well, even after pre-medication, when they gave me 1 cc of iodinated contrast, I went into anaphylactic shock, had to be intubated, and I was in the hospital for almost a month." He says, "Now will you still consider working on me?" And I said, "Yes." He paused for a while, and he looked at me, and he says, "Are you crazy?" I said, "Well, that's a different question altogether. But my plan is we're going to try to use CO2. I was getting ready to leave for China, so I had that whole morning off, and I had the capability to work on both of this man's legs at the same time. He had come from Seattle, Washington, so that's pretty far away from South Louisiana. And so I did work on both legs, and I said, "I'll see you back in a month." But what I forgot to tell you was he had told me his creatinine had been 1.3 a year before, and he had only one kidney. I said, "So I'm going to ask you to allow me to do one more thing." He said, "What's that?" I said, "I'd like to look at your kidney artery, and if I find a problem, I want to fix that." So I went up, and he had a single artery, critical stenosis, just a 14,000 guide wire totally occluded the kidney artery. This was not a 90% stenosis. This was a 14,000 wire that occluded it. I fixed that. I fixed both legs. When I saw him back in a month, he had had the gangrenous toe amputated, and that was healed. He had the ischemic ulcer, which was markedly improved, and his creatinine was 1.5. That's when I decided CO2 was pretty important. And since then, I would say I use CO2 in about a third of my cases. And I'm going to get into why I use it so frequently. I can't use it in my coronary cases because of the motion. But we really underestimate the importance of contrast-induced nephropathy, and much to the negative of our patients. Contrast-induced nephropathy is the third most common cause of hospital-acquired acute renal failure, only behind true shock and the use of nephrotoxic drugs over long periods of time. It dramatically increases mortality, morbidity, length of stay, and cost. The average increased cost of contrast-induced nephropathy, I'm not talking about the patient who goes on dialysis, just the patient who has the bump in creatinine, the average increased cost in the hospital is over $10,000 and over $11,000, approaching $12,000 over the first year. And the only way we can absolutely prevent contrast-induced nephropathy is by not giving iodinated contrast media. Now, the definition of contrast-induced nephropathy is a rise in serum creatinine of 0.5 milligrams per deciliter, or a rise in serum creatinine of greater than 25% of baseline. And often we miss this in today's world because we do outpatient procedures. We think we're fine because the initial BUN and creatinine were okay. And we don't even follow this, but it does have negative implications. Now, in the past, Roxana Moran and her group looked at cardiac patients undergoing use of angiography with iodinated contrast, and they tried to create a risk score to determine who was apt to develop contrast-induced nephropathy. So if at any point during the procedure they were hypotensive, that gained an integer score of 5. If a balloon pump was used, an integer score of 5. If they had had congestive heart failure at any point in the past, an integer score of 5. Age greater than 75 years, an integer score of 4. Anemia of any sort, and this is just mild anemia, an integer score of 3. Diabetes, an integer score of 3. Contrast volume, you got 1 point for each 100 cc's of contrast. And then finally, based on your GFR or your serum creatinine, there were integer scores. Now, we have routinely looked at people's BUNs and creatinines, and we go, okay, they're not at much risk. How many of your patients are over age 75, have diabetes, and have mild anemia? A lot. And guess what? If you have those 3 things and you give any contrast, you're already at high risk of contrast-induced nephropathy. One of the things that we as an organization have to do is to let people know this is a much bigger problem than we historically think about it. Even in my lab, where guys hear me hone down on this every day, they give me one number. They come out and say, well, the BUN is 12. I said, that's great. What's the creatinine? What's the GFR? I got to know that. How old is the patient? What is their blood count? Are they diabetic? Because even if the BUN and creatinine are completely normal, if I give a bunch of contrast to that patient, I have a risk of contrast-induced nephropathy, and I make him more likely to die, more likely to have bigger expenses, and more likely to have morbid complications and increase the length of stay in the hospital. So, to summarize the problems with contrast-induced nephropathy, it increases both acute and long-term mortality. I'm not going to repeat the data that Jim has shown. It's a profound effect. It increases acute and long-term morbidity. It increases acute and long-term cost. It is strongly associated with independent risk factors that we can easily assess but rarely do in cath labs throughout the United States. And finally, in big red print, we have to avoid contrast-induced nephropathy. This has to move its way up the flagpole and assume the significance that it is due if we're going to have better outcomes for our patients. So one fact that is absolutely clear: the only way to absolutely avoid contrast-induced nephropathy is not to administer iodinated contrast media. Now, it's interesting, but I take on fellows each year. And as I start my peripheral cases with fellows, I only let them use CO2 at first. You might say, why is that? Several reasons. Reason number one, I want them to learn to use it. Reason number two, new fellows puff 1,000,000 times to see what's going on. They want to image from every angle, every direction, in every way. And by the way, they get over 100 cc's of contrast very quickly before they've even taken the important images. And I think every instructor in this room would agree they've seen that. They're so worried about missing something that they hurt patients. So we start with that. Now, in peripheral arterial disease, we have two options. We can use external duplex guidance, and I'll show you this in a little bit. It is not my first choice. It is difficult. It requires you have a very good tech in the lab. It sort of gets in the way of sterility. And frankly, sometimes I have to hallucinate the wires that I'm looking at. I'm much more used to using fluoroscopy as my method of seeing things, and CO2 angiography. And this has really, as I said, totally changed my practice. It is no longer a difficult way to get a bad image. It's an easy way to get a good image, and an image I might include that sometimes is not just as good as iodinated contrast, it's better. I don't know if any of you made it to the business of medicine and heard Fred Goad, who is the founder of WebMD. He was also, by the way, a base investor in Apple Corporation long before the IPO, in Microsoft, in Facebook. Fred, it did pretty well in life. But Fred wasn't doing so well in life because when he presented with a digital ulcer on his foot, he was ultimately found to have all vessels below the knee totally occluded, and was advised by both Cleveland Clinic and Vanderbilt to get both of his legs cut off. That's not so good, regardless of how well you've done investing. And some of that had to do with imaging. So when he came to me, ultimately after those places, I put a catheter down, antegrade. They had tried to do things contralateral. I took an iodinated contrast image, and all IP vessels appeared occluded. By his previous MRA, all vessels were occluded. By his CTA, all vessels were occluded. Yet, when I studied him in my office, I thought I saw duplex flow in the perineal. So I did a CO2 angiogram. And what he had was a critical, ultra-critical, proximal perineal artery obstruction. And we were able to then easily cross that with a wire, put a drug-eluting stent, and now we had a wide-open, big perineal artery to his foot, which gave rise to an anterior and posterior communicating vessel. And that probably alone would have saved his limb, and then we went after the AT as well. CO2 also gives images that are better at times because it's 300 times less viscous. And in critical stenoses, it may show us things iodinated contrast does not show. So it's more than just allergic reactions. It is more than just the ability to avoid contrast-induced nephropathy. It is a means in certain circumstances of better visualization. And where else I've found this, and again, Jim taught me this and showed me this, or in critically stenotic distal bypass grafts. I cannot tell you, since he's shown me this, how many cases I had done angiography and they appeared to be occluded, and I was thinking about how am I going to lyse this patient, only to use CO2 and realize it was a critical distal stenosis only, and all we had to do was balloon and not lyse first. That potentially saved bleeding complications. So thank you for what you've done, but it made a big difference, and I think these are issues that are not talked nearly enough about with CO2. So CO2's changed my practice in those ways, but there's no such thing as a patient whose renal function is too impaired. If you tell me your creatinine is 5, I said, okay, no problem. There's no limit on imaging. You know, when we used contrast and we had diminished renal function, we often did a lousy job. Why? Well, we would try to give so little contrast that we often would take insufficient number of images or angles to ideally determine the care. Doesn't matter with CO2. If I wait a few seconds in between, this is cleared, and I'm able to image from every angle that I require, and I'm able to get good post images. In addition to this, there's no pre-admission or prolonged stay. How often in the past did we admit patients overnight to hydrate and try all of these convoluted things to try to avoid contrast-induced nephropathy, none of which have great merit, but nonetheless we were shooting for whatever we could do. And finally, and I was struck by this by the earlier speaker, as he's talking about working on aneurysms, we can put very tiny catheters down and inject and see very well. Why? It is 300 times less viscous than iodinated contrast. And based on flow dynamics, flow is directly related to the fourth power of the radius, inversely related to viscosity times length. This allows you to use longer tubes, smaller tubes, and still achieve good imaging. Now, contrast-induced nephropathy is increasing dramatically in peripheral cases. Why is that? Diabetes is epidemic, and you say, well, that's true in America. That's true all over the whole world. There's an epidemic of this. As Yum Brands and Kentucky Fried Chicken get really into China, okay, their diet has not changed. We've just established the first dedicated limb salvage center in all of China, and I can tell you, diabetes is a huge problem. Secondly, more interventions are being performed. Next, more complex interventions are being performed. Any of you sat in yesterday's live cases saw that we are now intervening on things that you would have never considered in the past. These are cases that historically people said nothing can be done. Those are the common lesions that we work on today. We're working on older patients, and that is by necessity because our population is aging. The most rapidly increasing segment of our population are octogenarians, and that is not going to change. And finally, a point I want to make as many times as I can, even patients on dialysis have a major contrast risk. I cannot tell you how many hundreds of times I have heard my peers say, well, I'm not worried about contrast because he's on dialysis. That's really a dumb statement. It's dumb because if a patient is actively making urine, then that patient's volume status can very easily be controlled. If we wipe out that person's capability of making urine, we have now drastically worsened his or her prognosis. So we got a lot of reasons we have to be a lot more careful. And we have to be proactive, not reactive. We don't need to consider this after the case. We need to consider it up front. So again, as I take on these new fellows, I make them take all the first images with this. I let them take as many angles as they want. I make sure they understand how to use CO2, how to not inject it too hard to cause pain, how to make sure they use end-hold catheters, how they then perform stacking. And then after, as they've gotten better, then I show them how to augment it with a few isolated iodinated contrast images at key areas where they may need it. And with that, we've dropped contrast usage down, iodinated contrast usage, by about 90%. It's a big deal. 10 cc's is rarely going to hurt somebody. 200 cc's often hurts people. Now, why should we consider CO2 angiography? Well, we want to avoid contrast-induced nephropathy. We want to avoid severe allergic response, and it just takes one of these true anaphylactic reactions to shake us up a little bit. It's kind of scary when somebody turns blue and can't breathe. And I personally don't like that happening to me. Because it's lower viscosity, we can image via smaller bore, longer catheters. We can image in close tolerances. If we're using a 6 French device in a 6 French sheath, we can still typically inject around that and see what we're doing. And occasionally it allows visualization where we could not see with iodinated contrast. And it's cheaper than iodinated contrast. I had to fight with a hospital administrator because they said, we're not going to get a commander for you. And I said, well, why? And they said, well, because it's a physician-owned company. So I called up the company because I'd used it. I thought it was great. And I said, can I speak to the owner? It was the owner that answered the phone. He says, I am the owner. And I said, are you a physician? He says, well, I'm a retired podiatrist. So I went back to the administration and said, so a retired podiatrist is in another state. How is that a conflict? And she says, well, I'm just not going to get it. That's my decision. I said, no problem. I'd always, every time I went to that hospital, because I go there once a month, set up 15 cases a day at least. I set up none that month. None. And so the next, she called and says, is everything okay? I said, sure, everything's okay. So I went the next month, I set up none. They called again, Craig, you said everything was okay and that you understood. I said, I do. No problem. She said, but you've not set up anybody. You've always set up a lot of cases. Oh, I said, oh, that's right. And I'm not planning to ever set up any more cases because you don't care about your patients. Okay, I've asked you to do something that costs less than what you have, that clearly has proven benefit, and you told me you're not going to get it. So I understand very clearly what's going on. Your ego is more important to you than your patient care, and I'm not going to set up any more cases at your hospital. Well, I had a CO2 commander the next day, so it helped me get a commander, but we shouldn't have to have those kinds of arguments. This is mainstay. Now, optimizing CO2 images for those of us who weren't trained on this is important. You need DSA imaging, and it's crucial you get the patient not to move. Important to coach the patient ahead of time and do whatever it takes. You want to use end-hold catheters as it creates less bubbles. You want to image as close to the area you're planning to visualize as possible. You want to do a slow, low-pressure injection because even with low pressure and going slow, since it is 300 plus less viscous than contrast, it is by definition 300 times easier to inject. You want to rotate the patient or the camera if there's excessive bile gas, and you want to consider glucagon. And you have to realize gravity affects imaging. This is lighter than water and tends to float. Now, here you may say, what about this using occasional puffs of iodinated contrast? Well, Seeger has shown us very clearly that if you use CO2 alone, it's pretty good. But if you supplement this with even minuscule amounts of iodinated contrast, it is better. This is the device I use. It's been easy. I've tried those other devices in the past. They're just too darn cumbersome. This is set up easier than the standard device, and it's worked very nicely in our lab. So here you see a patient with dense calcium. People told me you're not going to see well through that. So let me just show you. I couldn't see with regular contrast, but here I'm doing an injection right near this lesion. You can even see the microchannels. It allowed me to negotiate the microchannels, first to the left, then back to the right. We crossed this very quickly once we saw those microchannels. How do you think this looked by iodinated contrast? It was a total occlusion. I could even see the microchannels here on magnification, made crossing this incredibly easy, as long as I was willing to make the Z that the wire had to follow. Now, so this has really clearly changed my practice. There's no pre-admission for renal insufficiency, no post-stay for that, no pre-medication for allergy when I'm planning to only use this, and simply I don't rule out patients anymore. Now, what about ultrasound-guided access? Well, we use it for access and have for many times because there are many advantages. But we can also use this for other reasons and things like cross. We want to limit radiation exposure, the potential adverse effects of contrast, And sometimes we can't see with any form of contrast. For instance, if one has a total occlusion of the proximal superficial femoral artery, we may not know where to probe with the wire. External ultrasound will show that, even if it's occluded, and we can use that to help direct us. So here you see a patient, you don't really see an origin, but by duplex, you do, and that allows us to get into those areas, and we use these kinds of probes typically. So this is a patient that we treated just using ultrasound. Now, let me put this in perspective. For every one case I do with just ultrasound, I do over 100 with CO2. I'm far more comfortable with that, but this is also an option. An occluded popliteal, it's hard to know where you're going. Here we have a very distal vessel filling. So we're going to gain anterior and posterior access. Now I've gained ultrasound access into the AT. You can see the wires it's going through. But I'll be honest with you, I've got to bring in our better techs. I have to hallucinate seeing this wire a little bit. I'm using it as I feel when I meet resistance. I'm just more comfortable with a fluoroscopic image. But I can use this. Now I'm coming from above. I'm going to get down and I'm going to get to a point where I meet resistance. It's not moving. And whenever I get to that point, so we're going to come down. We're going to get these two catheters to meet. Now I'm right there, and unfortunately this video is not playing, but now I've got a catheter above, a catheter below. Now I use my x-ray and I steer into this catheter, and now I've crossed the lesion and I can treat the patient. This is also helpful, but I'll be honest with you, I'm a dinosaur. I like using x-ray. I think it helps me move the wire. But in this case, we're able to achieve very nice flow into the foot. And so these are many of the uses of ultrasound. Improves access, good identification of infrainguinal disease, helps me identify true luminal position in CTOs, and particularly those where I don't know where to start with my wire. It helps me appropriately size blood vessels, and it confirms adequacy of intervention. So in leaving you, I will tell you that I believe in contemporary medicine, doing peripheral intervention. CO2 is something everybody needs. You simply need it. Hospital administrators who refuse to get this, in my opinion, are making a fool's decision, because CO2 angiography is far cheaper at 2 cents a cc versus $1 a cc. It's safer. It's easier to set up. And for the life of me, I cannot understand anyone saying it makes no sense. Because then you're not admitting them before and keeping them after. You're not treating some of them with dialysis. Because I talked about a bump in creatinine. I didn't talk about dialysis. What happens if your patient goes on to dialysis? Well, he's more likely to lose the interventional success you've had. That's more likely to occlude. But in addition to that, he's in the hospital a long time. You know, if these patients go on to dialysis, do you know what the cost is? Over $100 grand. So this is a big deal. And we have far too long looked at BUN and sometimes creatinine, sometimes not. It's not enough. We have to assess the patients in terms of age, diabetes mellitus, overall health, all of these other risks. And I think then we have to make more appropriate decisions. And as we train fellows that like to puff a lot, we have to use things to let them see what they need to see to learn, but also don't hurt our patients. With that, I thank you for the pleasure of invitation, Jim, and I thank you for taking the time to teach, to come and teach a dummy like me how to use CO2. I appreciate it. Thank you much.